with us Dr. Joseph Johnson. He is basically a professor and head of clinical hematology, hemato-oncology and BMT unit at the CMC College, Ludhiana in Punjab. He initially did his MBBS and MD from CMC Ludhiana, and then DM was done from the CMC Vellore. And then currently the center is active in all kinds of bone marrow transplants. His major area of interest is hemophilia care, and he heads the comprehensive care center, which actively takes part in teaching and training for other hemophilia centers in Punjab. CMC Ludhiana also has DM clinical hematology since last 2 years, and they have started 2 seats per year. So if anyone wants to have hematology in DM, this is one of the options, right, sir? It's up to you now.
Okay, so thank you, Dr. Sanket and Dr. Shah and all Dr. Parimal and your team to inviting me. And I must appreciate the enthusiasm with which you are conducting this meeting. I am in the process of sharing my screen now.
Sure.
Okay. So what I would suggest is that please feel free to unmute and ask your queries as we move on. And we have already, basically, when you talk about pancytopenia, we're looking at reduction of all the cellular components in the peripheral blood, that is hemoglobin, WBC, and platelets. So for a moment, let us concentrate on these 3 cell lines. You've already had lectures on anemia and thrombocytopenia, and we will revise some of those approaches as well. So while we are approaching a pancytopenia, we are essentially running in your mind anemia, leukopenia, and thrombocytopenia. While approaching anemia, you have gone through laboratory and clinical approaches, and I'm sure Dr. Marban had gone through this in detail. Essentially, when you see an anemia, you're looking at 3 values: hemoglobin, MCV, and RDW. If you have an access to a reticulocyte count, fantastic. But most often the reticulocyte counts come after 1 or 2 days. So you are now looking at the hemoglobin, TLC, and the platelets, making a plan how you're going to evaluate, whether it is microcytic, macrocytic, or normocytic. In the clinical approach, you're looking at, is it a machinery or a substrate issue, or it is a loss, or it is even a decreased absorption. Essentially, we can lose blood through major orifices. So if you remember the orifices, it is easy to remember: urine, stool, uterus, and occasionally hemoptysis. Hemolysis is another area where it gets destructed. So the bone marrow is like a Boeing production line. So many nitty-gritties. To get this flight on the air, every nut and bolt is important, and you have to get this production going with accuracy. And that's what happens in the bone marrow. So you need the nuts and bolts, which is your machinery and substrate. And then there is a machinery that's a marrow. So nuts and bolts are your vitamins. You need to have a machinery from which it can be absorbed, and then only it can reach the machine, which is the bone marrow. So essentially, your nuts and bolts are the nutrition. Intestine takes it and takes it to the bone marrow to produce your blood. It can either be increased loss or increased destruction. So it can lose from the orifices, or it can be broken down. So when you're approaching an anemia, essentially you're asking 2 questions mainly. Is it anemia only without the WBC and the platelet, or is it all of them alone? The second question you're asking is the marrow responding enough? If the marrow is responding enough, that means you are losing from somewhere, that is hemorrhage or hemolysis. The marrow is not responding enough, which is the reticulocyte count percentage. Then comes a solution possibility that it is a substrate deficiency, or if the other cell lines are involved, it is more ominous, including the bone marrow, which is hypocellular or not hypocellular. So as we said, you look at the MCV, RDW, reticulocyte count, and then we say if the reticulocyte is low or high, is it a production problem or is it a destruction problem? From there, you rule out the substrate deficiency. Then you reach the hemorrhage and hemolysis. Hemolysis can be congenital or acquired. So let us sustain that thought there. You looked at the hemoglobin, hemoglobin is low. Can anyone tell me what is abnormal in this? What is your interpretation of this printout? I would like you to answer either by vocally or please answer in your chat box and I'll pick it up from there. Chat box. 47 participants. I want what is your interpretation of this peripheral blood report? As we move along, we are going to understand a little more in detail and then we will move on. I'm not seeing even one chat. Either right, I don't know is okay. Or you write cool question. Anything?
To all the residents, please something.
Yes. I am seeing MCHC is high, looks normal, sir. That is fantastic, Arjun Balal. That is a normal peripheral blood. Okay, next one. What is your interpretation here? Quick, your eyes have to go to the hemoglobin, MCV, RDW, WBC, and platelet count. Quick. IDA. Yes, absolutely right. So you guys are on the ball. It is the RDW is high and that is why it is IDA. Fantastic. Next answer. What does this film say? Eyes have to go to HB, MCV, RDW, TLC, and platelet count. Quick. Neha Dutt. Kazumi says platelet count, thrombocytopenia, 128,000. Okay. MPV is on the higher side. Micro hypo compensated by increased RBC. Maybe THAL. THAL what? THAL minor. Okay, Dr. Amy Trivedi. That's the answer. Okay, that's a thalassemia minor. Your eyes is on the hemoglobin. You need not have a high anemia level there. It is mild anemia if it is a male patient. I did not say the sex. MCB is low. RDW is normal. Platelet count lower normal side. It could be macrothrombocytopenia. Platelets are TLC is normal. Okay. Okay. What about this one? You just have to go at the hemoglobin, RDW, MCB, WBC, and platelet count. What do you see here? You see that the HB is on the lower side. MCV is also on the lower side. RDW is high. Platelets are low. And TLC is 12,500 with mild lymphocytic predominance. That's your interpretation. Okay, so now onwards, I'm training you to look at the neutrophil lymphocyte percentages. Get your mind oriented to this percentage and absolute counts. When you have 51% lymphocytes, you're looking at a 6,000 lymphocytes, right? And monocytes are high. So something abnormal. You want a peripheral blood to go on. Okay. There is dimorphic RBCs. There is a double peak here. There is thrombocytopenia and there is some lymphocytosis. You definitely want to see the film. And if you see a double peak, please understand it could be a transfused HB. So could have been an anemia, thrombocytopenia, and transfused. Okay, sorry. Okay, so here I already gave away the answer. MCB is high. So you're looking at your HB low, MCB high, RDW normal, platelets normal, WBC normal. Some NRBCs are seen, but again, you need to do the WBC film and then decide. So we kind of revised your hemoglobin issues. Now let's have a look at the leukopenia. This is how an electron microscopy film of a leukocyte look like. Look at the pseudopodia there. Okay. Causes of neutropenia can be either a WBC production reduction, destruction, like any other approach to any of the leukopenias or cytosis penias. You can actually look at this is a production. You ask the question, is it a production problem? Is it a destruction problem, or is it a sequestration problem? So you don't have to memorize the differentials and the decrease this thing. It should come naturally to you. Are we insulting the marrow, which is chemotherapy? Is the marrow being affected idiosyncratically with the drugs? Is it an acquired failure problem, which is aplastic or MDS? Or is it something infiltrating and replacing the marrow? Or are we giving radiation? If it is a decreased production, it could be pesticides, heavy metal poisoning, B12 and folic acid deficiency is one of the common causes of pancytopenia. Have a note for that. Please note that. Cyclical neutropenia, and these are rare situations, and I wouldn't go into much details. You can have the WBC being destroyed in bacterial infections, hemophagocytosis, infections in the newborns, autoimmune disorders, or even the drugs. So it's a destruction issue, replacement issue, or sequestration issue, like in hypersplenism or in Felty syndrome. As we understand the mechanism of, can anyone tell me the mechanism of leukopenia in typhoid? This used to be one of the standard questions in MD or in MBBS level. Anybody wants to tell me what is the mechanism of leukopenia in typhoid patients? We see in typhoid patients coming with fever, leukopenia, HB platelets may be normal. Anyone? I'll wait for 5 seconds. If no answer, I shall give you the answer. Okay, so I like your thought process there. It is not actually bone marrow suppression. It is basically, yes, endotoxin is the culprit, but it is basically, it is the margination. Absolutely right. Bhavin Patel is absolutely spot on there. It's the margination issue, right? Now comes approach to thrombocytopenia. You have already gone through this lecture once, and we will go and revise that. Again, decreased production, increased destruction, sequestration. Think about these 3 procedures, whatever approaches you want to do. Okay, it could be decreased production, aplasia. Increased destruction, it could be immune or non-immune. If it is immune, it is ITP mostly, SLE, NAITP, all that can be there. Non-immune is sequestered. More than 2/3 of the platelets are always homed in the spleen. Now comes putting all of this put together, you are now coming to pancytopenia. Clinical features are very simple. If the platelets are low, it will cause purpura. If the WBCs are not there, it could be bacterial or fungal infection. And hemoglobin low, it is anemia, you transfuse. So this is basically, if you look at the nose, there is a granulomatous lesion here. We say ecthyma gangrenosa. It's basically a pseudomonas related issue. Manifestation is a manifestation of the pancytopenia is an outcome of the duration of the neutropenia. That's an important point to understand, because the more you are in neutropenic period, more than 2 weeks, the probability of fungal infection shoots up exponentially, as opposed to the first 2 weeks where it is a bacterial infection. You survive the bacterial infection, patients are likely to get fungal infection. That's why high-risk neutropenias antifungal is recommended in, especially in aplastic anemia others. Okay, quiz time. I want all of you to answer in your chat boxes. Unfortunately, I don't have any toffees to give you, but I'm sure the organizers will ensure that you'll get some toffees or gifts.
I'll provide, sir. I'll provide.
Virtual toffees, huh? Okay, let's go. 25-year-old man presenting with fever, URI, 1 week duration, unremarkable and routine CBC analysis says so. What is your thought process here in terms of differentials? Come on, Bhavin. The best way to approach a problem like this is identify the findings. HB is low, MCV normal, RDW normal, retics are okay, viral URTI. Why would you say that? That's the answer I want. Why would you say viral URTI? And if it is a viral URTI, which viral URTI and why? Okay, you are saying lymphocytes are marginally increased. Pancytopenia with transaminitis, hepatitis. Okay, all of you are right. All of you are right here. But how do you explain the highlighted hemoglobin 10 and HCT 35? What's your interpretation there? See, look, normally we would expect the hematocrit, absolutely right. Smith-Shah is spot on. Hemoglobin is usually 1/3 of your PCV. When you have a capillary leak, your hemoconcentrate. So HV may be falsely normal or high. Now put everything together. Your pancytopenia, transaminitis, mild transaminitis, I would say, and capillary leak, mild lymphocytosis. What is the most likely infection? Which infection? Be more specific. Dengue, that's right. That's right. So why do you think there is leukopenia in dengue patients? URI in dengue will not explain your, that is there, but that does not explain why leukopenia, right? Okay, I'll give you a clue. The ferritin goes up and there is progressive pancytopenia which improves. There is a certain amount of hemophagocytosis which goes on, which is the culprit. Okay, there are various causes of pancytopenia going through the same production line. Again, our approach is the same for all the 3 cell lines. Decreased production, replacing the marrow, myelodysplastic syndrome, or it is abnormal machine or increased destruction. So 3 major components: decreased production, replacing the marrow, or sequestration subsequently, hypersplenism or increased destruction, and marrow is this thing. So you must remember the Boeing cell line and think of these parameters, you would hit spot on. Approaching your causes of, you are asking the question, is it a factory related problem? If it is a factory related problem, is it an empty factory, which is all the machines are taken away, or all the machines are abnormal, which is MDS or dysfunction, or there are no supply of raw materials, or all of this is gone to the storehouse and it is kept there, the hangars, and there is destruction as it comes out. So what are we looking at in a patient with pancytopenia? You're looking at the duration of symptoms. How long have you been like this? Where is the patient coming from? Because that has an implication in dengue or Kala-Azar or any other problems. Prior history of tuberculosis, prior medications, presence of lymphadenopathy, presence of spleen. Once you have a spleen, then you're thinking, are you alcoholic, non-alcoholic? Because the commonest cause of pancytopenia in our clinical practice is hypersplenism because of cirrhosis and portal hypertension. So that's an important aspect to look at if the patient has splenomegaly. Okay, quiz time. Okay, we asked the same patient. We talked about the viral infection. So say case scenario 2. And here we have a 50-year-old man, no bleeding or fever, referred to you with the following report. HB is 7, MCV is high, RDW is 16, bicarb, HCT is 22, and the same findings. Okay. And what do you think it is? B12 deficiency, aplastic anemia, megaloblastic anemia. Okay, these are all possibilities. The strict vegetarian, B12 is low, and therefore patient is now treated with B12 and folic acid. After a month of treatment, he comes back to you. Now HB has gone up from 7 to 8. Retics is 2%. Other cell lines are recovered. Now, what could be the possibility at this point? You are happy, you say, okay, continue B12 and folic acid, come back after 2 months. You are thinking an IDA underlying, there is a malabsorption. Yes, logical thinking, MDS or an aplastic anemia. But Mridul Mahajan, the MDS and aplastic anemia, the WBC and platelets would not have improved. Now you have to think of two things. Something which has improved is marrow, B12 is normal, anemia has improved marginally. These WBC platelets have improved, but anemia not satisfactory. So obviously there has to be an underlying problem, something else. So it's not adding up. You're now thinking like Sherlock Holmes, right? Is there something else? Is there something else fishy there? So now always consider dual deficiency here and screen for autoimmune hemolytic, autoimmune thyroiditis and pernicious anemia may coexist. Hypothyroidism can be there in B12 deficiency patients. Now the plot is thickening. You have given him hemoglobin. Hemoglobin remained 8 grams. You've given him iron. Now the retics has gone to 20%. There is indirect hyperbilirubinemia and LDH is high. Now there is hemolytic. Now Kiran Soni, you're right on that. Can you put your head together and say, what have you been dealing with all the while? So how do you explain the initial stages, initial situation? Now, autoimmune could be SLE and underlying PNH. Now, the questions we need to ask is, you are right on thinking in the lines of PNH. PNH with, now when you say, before you say PNH, now obviously your possibilities are there. When you say hemolytic anemia, it has to be acquired. It has to be acquired. It has to be autoimmune hemolytic anemia or PNH. You ask for a DCT, right? Because you want to rule out. In PNH, DCT will be negative. Very, very rare situations. PNH positive and DCT positive PNH could be there. Now, that was actually an autoimmune hemolytic anemia patient with an existing underlying iron deficiency anemia. It could be celiac. It could be nutritional. Developing a megaloblastic crisis. Now, when there is adequate and lots of hemolysis going on, there is a consumption of B12 and iron, which further causes the retics to come down. That is why sometimes this is a difficult situation in the OPDs when you have, but then there's a high indication, high index of suspicion will help you to get past this problem. Okay, case 3. 55-year-old man with hepatitis C infection, cirrhosis and portal hypertension, no fever or purpura. Examination reveals 5 centimeters spleen. What are your thoughts here? Hypersplenism. Okay. Hypersplenism secondary to. Now you have to think twice here. You are saying hypersplenism alone cannot explain the story here, right? Yes, HB is low, TLC is low, platelets are low, MCV is low, RDW is high. What else would you think apart from saying hypersplenism? Upper GI bleed? Yes, that's the right answer. So here is a story to fill up the line. There's a spin a yarn here. Patient has got hepatitis C, cirrhosis, portal hypertension. He's got a bleeding and he's got a blood loss, anemia. Okay, that's most likely. And if you do an iron, bone marrow, iron will be yes. Okay, same story continues. Okay, except that the retics have gone up. What's happening here now? Same story. The only change is now retics and hemoglobin. Now, classically in hypersplenism, even though there is a peripheral anemia and thrombocytopenia, there is no reticulocyte which goes up. Now, this is a situation you would want. This is a patient with generalized lymphadenopathy also. That's the addition here. Now, you have a cirrhosis, portal hypertension, hepatitis C, generalized lymphadenopathy, retics high. You must ask for, as soon as you see retics high and anemia, you must ask for DCT and TBDV to see if there is any hemolysis. If there is hemolysis, you want to rule out if it is extramedullary, is it extracorpuscular or intracorpuscular? And then you have to say, is it a intravascular or an extravascular hemolysis? And you do for considering hemoglobin and haptoglobin, right? Urine hemoglobin and haptoglobin. Request for a DCT and bone marrow examination. HCV can cause lymphoproliferative disorder. So that's a connection we need to make. AIHA. So this is a patient with AIHA at the face of it. Lymphadenopathy is a lymphoproliferation, and HCV is known to cause predisposed patients to lymphoproliferation. Okay. Some numbers have changed. 10-year-old boy with fever, URI, scattered bronchi, and blood counts are like this. He was treated with antibiotics, and I want you to respond to this well. Okay. He was treated with antibiotics, 1 unit of blood along with pre-medication, Avil and hydrocot, like a standard therapy. Have a good look at the CBC, and you would encounter some of these patients again. After 5 days, he's brought to you, and he's saying that lethargy is there. HB is 6.5 now. Retics are the same. HCT is not changed much. TLC has come down from 18,000 to 22,000. Platelets have also dropped further. What are your thoughts? Parvo. You are suspecting parvo causing pancytopenia, but listen to this story carefully. Leukemia. Neelu Sonaji has cut the chase faster. That is because this gentleman, this boy, received hydrocot. Now, this is a common mistake which people do. Never give pre-medication with hydrocot unless patient has reaction. Do not use it in your standard practice of hydrocortisone. If somebody is already doing it, please discuss with your seniors and not do it again. And what has happened is that it's probably had ALL. The steroid has actually caused the TLC to come down. And this is often, okay, Dr. Girish wants to say something. So this often can lead to a misdiagnosis or a delayed diagnosis. So please be wary of this problem. Requesting for a blood film and alerting the hematopathologist is the key here. And even a 1 dose of steroid can cause disappearance of these symptoms in the peripheral blood. Okay, last 5. 30-year-old man with high-grade fever for 10 days has gum bleed and purpura, reveals a 5 centimeter spleen below the costal margin. What are your differentials? So the approach is like this, AML. Okay. You can't conclude here AML. There is a splenomegaly. In fact, ALL would have been a reasonable response. AML M4, M5 is more specific, absolutely fine. But how can you be so sure that it is AML? It could be ALL. All you can say, it could be acute leuk. There is pancytopenia, there is lymphocytic predominance, there is splenomegaly, and therefore, what is the disease it cannot be among the causes we said? In this particular situation, what is a diagnosis which is not possible or unlikely rather? Among the pancytopenias, we talked about B12 deficiency, we talked about MDS, we talked about aplastic anemia, we talked about acute leukemia, AML, ALL, we talked about cirrhosis and portal hypertension. What among these diseases which I labeled is it cannot be aplastic anemia? That's right. If you have a splenomegaly, you cannot have an aplastic anemia there. It's not that strict, no. If you have a splenomegaly in an aplastic anemia, it could have been a pre-existing aplastic spleen, or patient is developing infective endocarditis. Okay, so we move on. OTPT is a bit elevated. Creatinine is 1.2. Now your approach is like this. Now he has bicytopenia, pancytopenia, retics are low, neutrophils are low. We need to do a marrow here. That's the first question. If it is hypercellular, then you say it is dysplasia, blast or secondaries. You are asking the question, is the marrow reserves good or not good? And Marrow would have told us the answer. Now, in this particular situation, this is unlikely because we are saying there is splenomegaly. It could be one of them, right? The patient has none of this apart from a cellular hypercellular marrow. Okay. Now the plot thickens here. None of these problems. Marrow is hypercellular. What are your possibilities? In other words, a 30-year-old man with high-grade fever with splenomegaly. There is pancytopenia. OTPT is marginally elevated. Creat has gone up. We've done the marrow. It is cellular, not hypocellular. It's got to be one of them. No blasts are increased. What are your thoughts? In effect, in other words, if it is an inexperienced person who may contact you and do the marrow and send it to you, and now you need to think, okay, lymphoma is a reasonable thought, but if it was hypocellularity because of lymphoma or hypercellularity because of lymphoma, Marrow should have picked it up. Early myelothysis. Okay, so you are bringing up the proposition that this is an MPN patient who had this fever. Fever is the only thing which is not fitting in, right? Now, when we approach, we use the principle called Occam's razor. I'm not sure whether you have heard of that. Occam's razor means try and explain all with one possibility. If you bring in myelothysis, spleen is explainable, pancytopenia is explainable, cellularity is explainable, but fever, then you have to say it's an adjunct. He is an MPN guy who's developed fever. Reasonable thought. Just infection and leaving it there may not help. Now, if it is infection, of course, there is fever. It has to be either inflammatory process or infective process. If it is an inflammatory process, then it is an SLE in those connective tissue disorders area. If it is an infection, your procal is high, it could be reasonable. Yes. If it is infection, how does it cause pancytopenia? We talked about it just now. Think. What is it that can cause pancytopenia when the marrow is cellular and autoimmunity is not there, triggered by an infection? Okay, so HLH. How do you make a diagnosis of HLH? I need you to type in quickly. You're suspecting HLH. What test do you do to make a diagnosis of HLH? Yes, triglyceride, ferritin, and one more. Of course, soluble CD25 we do not have, but yes, fibrinogen. Triglyceride, yes, that's good. Okay, 30-year-old man, same story, repeated, platelets are 20,000 and spleen is not so large. Liver is 3 centimeters. Same story, pancytopenic, lymphocytic predominant. And now bone marrow aspirate is reported normal. Trephine was inadequate. Now this is a real dilemma situation. How would you handle this problem? Viral markers, say viral markers. What viral markers? A question: EBV, CMV, HIV, HV, HCV, negative. So now looking at the thought process here is pancytopenia, no splenomegaly, no lymphadenopathy, liver is 3, and high grade fever for 3 days. I mean, spleen is there. Sorry, spleen is 3 centimeters. Could be viral. Agreed. I'm not denying that virals can cause this. Just to make you understand that refined biopsy is important here. Okay. If you have treated and we did a repeat marrow and we found refined TB granulomas there. Sometimes we can miss it. When in doubt, you must follow the dictum. TB can cause everything other than pregnancy. Okay, dictums to follow. Okay, last 2 questions, 3 questions. For 40-year-old man, previous history of left lower limb DVT now, 5 years ago, presence with the following counts. For an interesting calculation, I've kept the same counts. Platelets have gone up a bit. HB is 3 times bicarbonate. HCT is 3 times the HB. He just had a DVT. That's all he had. Bone marrow examination showed 30% cellularity with increase in mast cells in a 40-year-old man. What are your inferences here? Okay, so good. Somebody has thought through PNH, and we are thinking that it is somebody who has developed DVT, and the marrow is showing cellularity and increase in mast cells, and is an evolving aplastic anemia. And of course, you would have asked for a CD55 and CD59, DAF and Marrow. Spot diagnosis with no other discussions. Okay, it's getting too delayed. And I mean, in terms of the response, what is the abnormality you are seeing in this picture? Yes, you're right, Fanconi, because of the polydactyly. Hyperpigmentation, polydactyly are features of Fanconi, and you do a test called stress cytogenetics. Okay, last case for the day. 33-year-old lady presents with complaints of intermittent episodes of gum bleed for last 1 week. Ecchymotic patches are there and DVT of lower limb. Gel physical examination shows purpura, ecchymotic patches, no lymphadenopathy, organomegaly. Essentially, we are looking at a just mucosa and skin involvement, skin mainly only, and mucosal involvement in a 33-year-old lady for 1 week duration. That's the parameters. There is pancytopenia. So pancytopenia in a 33-year-old lady with DVT when the biochemical parameters are normal. So here we are saying that there is no features other than these, and there is unlikely to be HLH. PT, APTT were as follows. And you rightfully said, what would you request a pathology doctor to look for in the film? Pancytopenia presents a 33-year-old lady and you want to look for schistocytes. Okay. Pancytopenia and schistocytes don't go together. If there is TTP, it is usually TLC will be normal. So imagine today you are on call and this patient comes to casualty. This is the initial printout which comes to you. HB is low, she's bleeding. Platelet morphology is normal and platelet is smear platelet count is also the same. It's not more. Patient is bleeding, mucosal involvement, general physical examination has ecchymotic patches, short duration history with pancytopenia. This is a printout which comes from the technician. You are now going to call that. Yes, I like that. Jigar Singh has gave me the answer which I was looking at. You have an APTT which is prolonged. PT is prolonged. Points to learn is promyelocytic leukemia is a medical emergency with bleeding and thrombotic manifestations. One of the commonest causes APML. They can even present with cortical venous thrombosis. In fact, this is a diagnosis which can be missed if you are not cautious. We won't even probably do the marrow because people will be so busy with managing the rest of the problems. Unless a time comes, a smart resident or a technician comes back and tell you. If you do not have the luxury for those people, then you need to ask for it and come to an answer. So there are other causes of pancytopenia in the common situation. That is a post-op patient developing pancytopenia. Nitrous oxide anesthesia is one of the causes, but we don't use that so commonly now. Some of them actually depletes the B12, and sometimes that is it, or it could be drug induced. Myelofibrosis, massive spleen, large spleen, marrow dry tap, or even there is a tap, but there will be fibrosis in the marrow. MDS is an often overlooked diagnosis. Unless you have the trained eyes, you can miss it. The key to remember is that in an older age group patient, higher cellularity, B12 is ruled out, you're treated with B12, not improving, pancytopenia persisting, think MDS. Hairy cell leukemia is usually a giveaway with the hairy cells seen. So that's usually easy to diagnose. Leishmaniasis, massive spleen, where they're coming from, AG reversal, and they may or may not have fever. That would weigh, and marrow usually gives a diagnosis. So how I approach? Ask the age. So usual situation, pancytopenia referred to hematologist or a pathologist. Age and duration, because that will give you a lot of insight into the problem. We look at a temporal profiling of the problems. Is it symptomatic, asymptomatic? Is there an organomegaly or a lymphoproliferation? That's a question first you are going to ask. Is the patient symptomatic, asymptomatic will tell you whether it is an hairy cell leukemia type of a guy or a cirrhosis portal hypertension guy. On the other hand, is a HLH or an APML guy is angry, is alarming and telling you I have a problem, please come and treat me. Those two contrasting presentations of pancytopenia needs to be looked at. I do a baseline examination to baseline investigations to see if it is, this is wish list. If you have a hemolytic anemia patient or a pancytopenia patient coming to do it. Otherwise, based on your zooming in and zooming out of the potential differentials, you now tailor make the differential of the test which we want to give. B12 folic acid serum ferritin is another test, and then doing a marrow, deciding on collecting to the IPD cytogenetics, which is very important. Within 24 to 48 hours, you should push your labs and your center to be able to give you the diagnosis. Now, this is a common problem. I'm not too sure how much of this is there in Gujarat. There is always a tension, okay? This tension is a healthy tension most often between the clinician and the pathologist. That's the communication which goes. We have sent you the sample. I am seeing the patient. Why don't you give me the diagnosis? Pathologist said, you are not writing anything in the form. If you don't write anything in the form, I'll give a machine printout. Asking, you are trained for 3 years. I am also trained. You should better tell me the diagnosis. Why should I tell you what I think? I want to know an independent diagnosis from the pathologist. And pathologist gets to say that you will never understand. And the key is appropriate communication. That cross talk between the pathologist and the clinician is the most important key in dealing with hematology patients. Without that, I don't think we can move 1 inch forward. Dr. Parimal has agreed vehemently, and I'm sure Parimal may have had situations. All of us agree with it, especially the pathologist gets to be on the receiving end most often, because you will get the brickback from the doctors, the consultant, the clinician saying that, why would I write there? And unless a clinician has gone through the labs, like all hematologists have, and had a full gestation period in the pathology lab, you will not understand the importance of seeing in the slide and correlating with the clinical findings. So short of that, it's the best thing to ring up a call, pick up a phone and talk. I'm thinking about this. What are you seeing? Hey, can you look for this as well? Okay, give a good history. Like any research question, asking the right question is the most important thing than the answers, which means the take home should be, why is the APTT prolonged? Why is the PT and APTT prolonged? Why is the platelets down and there is no splenomegaly or splenomegaly? Asking those questions will give you a lot of answers, and each patient will raise at least 50 questions and you will get the answers within seconds. Actually, your brain has the potential to process all of them. Think in terms of decreased production, increased destruction, and sequestration. We talk about that. If you have no money in the purse, it's either you're not putting money there, or it's getting, the pocket is down and it is going out, or you're spending too much. There's nothing else can put less money in your pocket, right? Looking at the lab indices carefully. What is this careful looking? Hemoglobin, MCV, RDW. Your eyes goes to the WBC, then comes back to the platelets. Look at the graph if you have. Communicate with the lab frequently and take home. Do not give steroids